Okay, welcome to this lunchtime seminar, and thank you for all the colleagues that have made it, joining either in the room or via the web stream. We're excited to be here today and to also start the year with some interesting discussions and presentation on testing. This is part of a series, and there will be more coming your way. So let me introduce our speakers for today, starting with our keynote speaker, Dr. Carla Makhlouf-Obermeier. Carla is a research professor and director of the Center for Research on Population and Health at the American University of Beirut. She has been a scientist at the HIV department at WHO for many years prior, and a faculty member in the Department of Population and International Health at Harvard. She has led a number of multi-site research projects, including the MATCH study, which she's here to speak a little bit to us about today. And she has published over 100 articles and 4 books on a number of international health topics. Also joining us is Cheryl Johnson, who works in the WHO HIV department. She works on HIV testing and has been lead consultant on WHO and UNAIDS work on self-testing. She was previously with USAID in Namibia and HQ and has worked on an assessment of HIV self-testing kits in private Namibian pharmacies. Then we have, to the right of Cheryl, we have Katie Curran, who is also working in the HIV department at WHO currently on issues relating to HIV testing and PrEP. She completed her PhD in epidemiology at the University of Washington, where she conducted research on HIV prevention for HIV serodiscordant couples in East Africa. Last but not least, Anita Sands, a familiar face, certainly in WHO and UNAIDS. She's been with WHO for 10 years and is working as a technical officer in the Department of Essential Medicines and Health Products. She's an expert in HIV testing, laboratory, and quality assurance, and these are the issues that she will bring to our conversations today. Prior to joining WHO, Anita was a laboratory team leader at the National Serology Reference Laboratory in Australia. And then finally, of course, you'll know Rachel Bagley, who is leading on HIV tested related work and other work in WHO HIV department. So without further ado, I will pass over to our to Rachel to say a couple of words.
I just want to thank UNAIDS hugely for this opportunity to work together on testing. I think this is a great partnership, and we really are a model for how WHO and UNAIDS should work together. And I think this is a great tribute to UNAIDS. So, yeah, let's kick off. We're hoping to have some very short, punchy presentations, and then the main speaker will be Carla, who we are so pleased to welcome back. I just also wanted to pause for 2 seconds, really, just to say a word about Andrew Hunter. Andrew Hunter was a very close colleague of ours, and we worked with him most recently in Thailand, where he was pushing for increased community-based testing. And as you all know, he passed away very suddenly over the Christmas holidays, and this is a great loss, but we hope that we can continue his vision to make testing much more available by community-based organizations and by lay providers, particularly for key populations.
Hello, thank you so much for having me. I'm just going to give a few talking points on self-testing. So basically, what is self-testing? It's a screening test that's performed and interpreted by the person who is testing themselves. Some key things to know is it does not confer a diagnosis, and a reactive test does require confirmation. It has the potential to increase the number of people living with HIV who are diagnosed, who know their status, who have access to testing, and who have access and can initiate treatment. Several possible approaches that have been discussed at meetings and within WHO and UNAIDS have been a supervised or unsupervised approach. When we say supervised, what that really is referring to is that health workers or volunteers can provide support before someone tests or after. And this can be a demonstration of how to use the test, counseling that can be provided, and then unsupervised self-testing is really more of this over-the-counter approach where it's freely available to the public. There may be an insert or a leaflet, a referral card, but there's not direct support from a volunteer or a health worker. Then there's also approaches about how it's distributed. So it could be community-based, where it's a community-based intervention, where somebody's providing a self-test and following up. It can be facility-based, where health workers can self-test, or a health worker could provide a self-test to someone so they could test in a private room in a facility. And then there's alternative places where you could also do tests, churches, public venues. There's multiple, countless ways you could think about it. And then there's also different approaches that have been discussed about restrictions. Should it be clinically restricted and prescribed by physicians? Should it be semi-restricted, available through facilities only? Could it be unrestricted through vending machines or completely public within grocery stores? Just a quick background on some of the work that we've been doing. There was a literature review in 2011 on self-testing among health workers, and there was also a 2007 survey done by Liz Corbett with WHO support about self-testing among health workers. Rachel actually published a systematic or literature review on self-testing on the research and policy areas. There was the symposium this past April. That was the first international symposium on self-testing, so that was a big achievement. There was also the UNAIDS Science Now featurette on self-testing. And most recently, the self-testing was featured in the sex worker implementation tool that was launched in December. There is the technical update that will be forthcoming from UNAIDS and WHO on self-testing. And this is also going to be included in the January update of the ARV guidelines. And we're coordinating currently a special issue on self-testing in AIDS and behavior that will be launched this July at AIDS 2014. And just our ongoing activities are really coordinating with researchers and implementers and trying to facilitate engagement, where WHO and UNAIDS can kind of take the lead in that way. Just some key lessons learned to share of where we are is that we've kind of learned self-testing shares a lot of characteristics with current HTC approaches. So that's the products, the accuracy issues, the linkage issues, potential benefits and risks, and regulatory policies. Many of those are very similar to what we're used to within HTC. The HIV RTTs for self-testing, they are considerably accurate, but it's important to note that suboptimal test sensitivity and user errors are potential problems. Clear instructions for use on how to perform a self-test and interpret those results are needed, as are regulatory processes. Systems are needed to guard against potential risks and coerced testing, for instance, and facilitate linkage to further testing, prevention, care, and treatment. Self-testing is already formally and informally available. So at the symposium and through several consultations, we're aware that self-tests are being sold, whether they're regulated, and in a few countries like the UK and France and the US, there's been more discussion about a regulatory process where they're approved and regulated by the government for sale. Research is continuing, but current evidence is limited. So on our end, we've really been trying to push the agenda to get more evidence, to build that base so that regulatory policies and national testing policies can be informed, and then WHO normative guidance could be made. Just a quick update on where we are. There's only one over-the-counter HIV self-test kit that's been stringent regulatory approved. So that, like I mentioned, there's discussion about approval in 2014 this spring in other countries where it could be used, but right now it's only approved for use in the US. Overall acceptability is relatively high, between 74 to 96%. Prices range depending on the context. So as you can see in the example, in the US, it's about $40. In Namibia, it's about $6. And it can vary and be even less than that or a little bit more. And then like I said, they're considerably accurate. Most studies have reported a sensitivity greater than 91.7%. But again, there's limited evidence, so that's something we're continuing to look at. And then the linkage data, that's a significant research need. There is one study that reported a 3-fold higher rate of ART initiation with the support of a community-based health worker and with home-based ART initiation. So that's a very, there was a presentation actually here this summer on that, and so that's very hopeful about the options for linkage, but that's something we still need more evidence on. So just something about what's happening next, things to look out for is that there are several ongoing pilots and long-term studies among general populations, couples, health workers, sex workers. A pilot study is currently going on in Zimbabwe and among sex workers, and there should be another one in Uganda that's going to be coming forth. There's an upcoming Gates meeting, February 2014, to share about some pilot study results that will be in Nairobi. There is one private sector assessment on over-the-counter self-test kits in Namibia. There's ongoing research in the US among the general population, ED patients, and an MSM. And there's a very innovative pilot. They published a case study using vending machines outside of a health clinic. And so there's a self-testing and mHealth implementation program in South Africa. It's a pilot program. And then self-testing is being included in several PrEP demonstration projects in the US, Kenya, and South Africa. So, off to Katie. Sure.
I suggest we keep questions until the end, unless there's something very urgent now. If not, I think we'll go on to the next presentation.
Good afternoon. On behalf of colleagues at UNAIDS and WHO, I'm going to share with you an idea that we've been working on for a new approach to community-based HIV testing, which we've named Test for Triage. So in 2012, an estimated 118 million people in 124 low and middle income countries received HIV testing and counseling. That's quite a lot. And it's been an increase since previous years. But despite these achievements, significant challenges remain in HIV testing and counseling. And two challenges I'd highlight. One is just increasing access to HIV testing and counseling so that more people know their HIV status. Importantly, key populations. And two, ensuring high-quality HIV testing results. False positives potentially are a major problem, particularly in some settings with immediate ART initiation and option B+. Community-based HIV testing and counseling is essentially any HIV testing and counseling done outside of a health clinic or facility. It has the potential to increase uptake of HIV testing, reach populations that are less likely to access health services such as men, adolescents, or key populations, and has been shown to test people who have a higher CD4 count. In the ARV consolidated guidelines last year, WHO recommended community-based HIV testing in generalized epidemics and also in key populations in all epidemics. However, there are still some challenges to the adoption and expansion of community-based HIV testing. For example, only half of 84 countries reporting had policies that support HIV point-of-care rapid testing by lay health workers. So innovative approaches to community-based testing are needed. And the test for triage is one idea. And this is to simplify community-based testing to a single rapid diagnostic test. So in a community setting, a provider performs one rapid diagnostic test, and people who have an HIV positive result are immediately linked to HIV testing for diagnosis, care, and treatment. Those who have a negative test are given their result, and repeat testing is recommended according to current recommendations and guidance. So the emphasis is on getting more people tested, and also having the HIV diagnosis happen at a health facility. So when they're referred to the facility, you start the national testing algorithm there. Here are a few potential advantages we see to this test for triage approach. One is to simplify the testing process and training needed so that providers are trained on one test kit instead of 3, and having a faster initial visit in the community, which could mean less waiting time for clients. This would simplify the supply of test kits and could lead to less wastage. It also would be less expensive per person tested at the community, and it increases the scope of practice for community health workers or non-clinical health workers. It also could lead to more reliable HIV testing results, since the through national validated testing algorithm starts when the person who has an HIV positive test is referred to the HIV testing clinic. There are some potential challenges that we are considering. One are policy and regulatory issues. Who can perform these tests in the community? What policies are set up that allow for rapid diagnostic testing and community-based testing and testing strategies? Immediate referral for confirmatory testing may be difficult in some locations and settings. Linkage to care and treatment, and getting proper training and support so that the messages are clear, that people understand that an HIV positive result is provisional and is not a definitive diagnosis. So what are the next steps? We're working on a policy brief, and we're really interested in getting everybody else's feedback and opinions on this new approach to community-based testing. And we're also curious to know how WHO and UNAIDS can help countries reform and revise their community-based testing strategies.
Okay, so I'm one of those people that prepared more slides than I'm allowed to, so I'll try to get through them quickly. It's an interesting subset of people we have here. I'm always referred to as the lab person, which I kind of find quite unusual because most of the rapid tests that are performed these days are all performed outside of laboratories, so perhaps more the diagnostics person. But I'm going to talk a little bit about the quality of HIV testing as a whole, meaning not just the quality of the test that's used itself, but the testing process. Next slide. Oh, you're on it. Okay. So in terms of understanding quality of testing, you have to think a little bit about the drivers. So it's not just, is this rapid test good quality or not? It's the way in which it's used, and thinking about the way in which testing sites are organised, if they're very busy sites, and also if they're not busy sites, if you don't have very many patients coming through per day, if you have short opening hours that are not convenient for people to come to, if you have few staff that have many tasks, these are all sorts of drivers that start to incentivise poor test procedures being undertaken. We do have a lot of issue with poorly trained, poorly supervised staff, and really the proficiency of a lot of our users can be questioned, particularly ones that are in low throughput sites, particularly for the second and the third test. They may be very, very proficient in the use of the first assay, but less proficient with the third assay if they only use it once every week or maybe once every 3 weeks. We still do have an underlying issue with poor quality tests, and we find that in some countries where open competitive tenders are the way in which tests are procured, sometimes the cheapest test, not necessarily the best quality, may be procured. Stockouts are always an issue. Lacks record keeping, and this is sort of something we'll come back to and circle on a little bit, but if you cannot actually accurately quantify who you're testing. It doesn't need to be the name of a person, but you need to be able to identify who you're testing, what their results are, which tests you used to test them, what the expiry date of that test was, who was actually the operator, the staff member that did the testing. It's very important to be able to record prevalence rates, discrepant rates, and actually look at how inconclusive results are followed up. And often we really don't know what the quality of the testing is. We don't know because we don't quantify it. Next slide. So I'm just going to step through, and these are my sort of spacer slides, to sort of talk about the 4 elements that we sort of see should be used as a basic principle to assure the quality of testing. And the next slide. We have 2 HIV testing strategies. This is the testing strategy for high prevalence. This is the WHO strategy. You can find it in a number of our documents, including our latest report on laboratory evaluations. This is the traditional 3-test strategy, and it would be the follow-on from a test for triage. So we talk about A1, A2, A3. The test for triage in the community would be an A0, so to say, and this would be the facility-based testing. And the next slide is on low prevalence. This is a different strategy to the one that is recommended by CDC. We do feel that the tiebreaker approach in some settings overdiagnoses people, particularly if a very poor specificity 3rd test is used, and I find very, very often people are so worried about sensitivity of the tests, they neglect to choose a test of high specificity, and this really does increase the number of false positives in your population. Using good quality tests, and we can go to the next slide already, the WHO pre-qualification program performs laboratory evaluations of currently available tests. The latest report actually includes the results of some of the tests that we've been evaluating, not just pre-qualified, but any of the test results that we have. So you actually can also start to see those tests that are not pre-qualified, what their evaluation results may be. This is sensitivity, specificity, invalid rates, interreader variability, which is quite important. And we also have a list of products that are eligible for WHO procurement on our website that countries can use as a guide for good quality tests. Next slide, please. Next slide. National testing algorithms are very important. I think it's a fairly well-established concept in many countries. However, many procurement agents and donors are less aware of the way in which we actually work with countries to validate a testing algorithm in order to streamline procurement processes, to streamline training needs. If you change the test every year or every 2 years, you have to retrain your health workers. And what we find is that if people have used the Determine for the last 10 years and they receive a new test, well, they'll probably just use the same procedure they've always used for Determine, the same reading time, the same number of drops of buffer, etc. So we actually find that validating a testing algorithm is good from a programmatic point of view as well as from a technical point of view. However, you do need to have a backup. So it may be that you have one testing algorithm that's used most widely, but you have an additional 1 or 2 assays, and that can actually give you another set of maybe 2 or 3 or 4 algorithms. And this can be very useful in the case where you have a problem with a particular lot of product, or you have a problem with the product as a whole and you can't use that whole product, or if you have a stock out, obviously that'd be a similar sort of situation. So obviously looking at an assay that's most sensitive as your first screening, so you capture any possible reactive positive patients in your population, and then assay 2 and 3 being most specific to rule out any false positive results. Next slide. And the next couple of slides are really probably the more important aspects, because they're the forgotten aspects. They're the aspects that just seem so obvious that we overlook, reiterating time and time again to follow the instructions for use issued by the manufacturer exactly. In the context of pre-qualification, we spend a lot of time looking at these, the leaflet, the kit insert, the piece of paper that's in the test kit, to look, are they logical, for one? Are they clear? Are they unambiguous? Are they written in language that is understandable by lab people, by non-lab people, by community workers, by those who have just been given a job in the testing site and it's their first day. So in particular looking at the storage temperatures, but also delivering the exact volume of specimen, using the specimen transfer device that's in the kit. I find very often I'll go to countries and I will see they actually don't have any pipettes. I'm like, well, how do you possibly put the blood on the test? Oh, I just lance the finger and just drop it over, and it sort of falls in eventually. And it's sort of, well, how can you control the volume of specimen? But that was because they had a stock out of the pipettes, or a stock out of mainly of the pipettes or of the buffer. And so buffer is also a very critical part of the test procedure. People worry very much about how does that test perform, but they don't have such a worry often with interchanging buffers. So if I run out of buffer from one test kit, oh, I've got a little bit here left over from another one, it's an expiry date, I'll just, it's all just liquid, isn't it? And unfortunately, the control lines on the tests just control, in general, most of them control for the addition of liquid. Very few of the control lines actually control for the addition of specimen. And it's actually a point of difference, I would say, actually, when you're thinking about selecting a test, is looking for a test that does control for specimen addition. Next slide. The other point where we've had a lot of issue, and most recently with a product which was delisted from WHO's list of test procurement, is reading time. And we find actually, I've given a few examples here. These are just some of the ways in which it is sort of presented that you should read a test. And this sort of links back a little bit to my first point about the place where testing's is occurring. If it's busy, if you are in an ANC clinic, you're only open 3 hours in the morning and you have 100 women who, you know, and your prevalence is 5%, so you most likely have a lot of A2 and maybe A3 tests to perform. Looking at ways to economise your time as a health worker and as a tester is pretty useful. So we've found very often that manufacturers are also looking for a competitive advantage. So if they can say, for example, the third one down, the result can be seen within 2 to 3 minutes for a strong positive, but don't interpret after 30 minutes. What that means is essentially you can just sort of sit there for up to 30 minutes and whenever you see a line, read it. I mean, it's very, very difficult from a practical point of view. That assumes that, you know, the counsellor is sitting there with the individual and we're having a bit of a chat while we're waiting. It's just not practical in terms of busy services. And if we want to scale up, we need to really think about very clear time. So perhaps the fourth one, you read at 10 minutes but don't read after 20. That gives you a 10-minute reading window, and that's a reasonable amount of time. We often find that tests that have a short reading window, a minimum of up to 5 minutes, the background is still very high and it needs time to clear. But some you could read at 5 minutes, and so we've actually spent a lot of time with manufacturers trying to make this a little bit clearer. And using a second reader actually to read test results and actually to read the report, to verify the report. This is again circling back to the point about good record keeping. How do you actually record the test results on that patient and the report, the final status that you gave them, so that you can make sure that that is followed through the system. Next slide. So just last 2 slides, so I'll be very quick, but there's no point just pointing out all of the problems and the challenges and the pitfalls. We need to do something about it. So in terms of how do we go about improving these sort of systems aspects to improve the quality of testing, obviously an emphasis on using a standardised logbook for record keeping, the use of unambiguous, concise, clear SOPs. These can be a one-page sort of laminated job aid in a way that you keep at the desk. Looking at better ways for the quality control of the test at the user site. The dried tube specimen, that's the DTS I have labelled there. This is a CDC approach to actually produce QC samples that you can use on rapid tests. This is because of the absence of test kit controls by many of the suppliers, and also the fact that this control line is not always specimen addition QC. And of course, EQA programs. This is when we move perhaps a bit more back to the lab world, where in a laboratory context, for laboratory accreditation, you must be part of a proficiency testing program in most of the stringently regulated settings, and that's very important. And one last slide is about training and support. We have a joint training package we developed with CDC. It's very comprehensive, and so it can obviously be adapted as the needs see fit, but we're actually looking to sort of update this, and so there's some work ongoing in the coming year to have, yes, a new product. That's all. Thank you.
Thank you, Anita. That's the end of our little brief update of some key issues that we're working on at the moment, and watch this space because there'll be more coming down the pipeline over the next few months. And now we're on to our main speaker, and we're very, very pleased to welcome Carla back to this building. She just informed me that it's 2 years since she stepped foot in the D building, and it seems like only yesterday. Carla was with WHO for several years, and this study that she's going to report on grew out of her work at WHO, and it's a real privilege for us to have her back and share the culmination of a huge amount of work. This really is one of the main studies on HIV testing and counselling that's happened globally over the past 10 years. So thank you, Carla, for sparing time from your busy schedule to come and share with us.
Thank you so much for this kind introduction. It's a real pleasure to be back here and to be at WHO and in this building where I spent many happy and interesting years, and to see familiar faces. I also think it's my privilege to be here and to share with you research results and think about their applied relevance. So when I was at WHO, I wanted to be connected to the research world that was outside WHO, and now I'm back to think about the policy relevance of this work. So it's a very nice opportunity. As Rachel mentioned, the work grew out of my work here, the project, and it's actually winding down. We have nearly completed all the analysis that we're going to complete. So this is a very good time for me to give you snapshots of the different parts of the analysis that we have done. I have a 4-part presentation with a brief introduction. I'll talk about the changing debates around HIV, describe the study, focus on some of the results that have to do with access and quality of services, then on some of the results related to consenting to HIV tests, and lastly, some of the results that stem from analysis of data on how partners experience testing. This is not new to you, but I think it's probably useful to think back about the major changes in the debates around HIV testing and counseling, because those form the background for this project, which was really motivated by the need to better understand what was happening on the ground, in the field, in countries, and complement the armchair and not so armchair discussions that were taking place at different organizations. And I think, at the risk of oversimplifying somewhat, I think we have moved through different phases in thinking about the debates around HIV, from the so-called exceptionalism paradigm, where in the early days of the epidemic, HIV was so different, the fear of stigma so great, and the lack of treatment so clear, that HIV was a death sentence, and only anonymous and VCT testing was acceptable because there was no advantage to test. And so the emphasis was on the right not to test. With the availability of treatment, the discourse changed to be the right to know your status, and testing was seen as the gateway to treatment, and therefore there was more of a rationale to encourage testing. I think another phase happened around 2006-07, when WHO, UNAIDS, and their partners decided that there were too many missed opportunities to test at health facilities, and therefore mobilized for the provider-initiated testing and counseling, which would be done instead of at the initiative of the clients for VCT, it would be done at the initiative of providers. But there had to be safeguards for human rights, so that the routinization of testing did not lead to lack of consent, lack of confidentiality, or poor counseling. And I should also add the linkage to care, which was also an important criterion for justifying testing at health facilities. And now we're in a sort of different universe, because as we'll see very quickly now, these debates are sort of really behind us. And now, as we've heard, rapid oral testing, testing in the hand of the clients themselves as self-testing. What's happening to couples testing? What's happening? There's something I came across called point of sex, which you can perhaps explain to me a little better. But there are these more instant, rapid, in the hand of the client sort of testing, which have really moved us beyond the early debates. But interestingly, in terms of the ethics and the safeguards, we've moved from the 3 C's as the requirements, the consent, confidentiality, counseling, to 5 C's, because we have to make sure that there are correct results and linkage to care, which are really important criteria. Through this, there's efforts on the part both of policymakers and people on the front line to really balance the individual rights and the benefits to public health. So this is in the background of the project. The project was, well, we also did a review. The project took place in 4 sub-Saharan African countries, and we did a review of policies, which actually appeared in a journal, which really summarized some of the main issues that we saw in the field. And interestingly, the preoccupations of people at headquarters and where policy and ethical discussions were taking place were not identical to what was in the field. So there was a lot, I think, a great deal more pragmatism among policymakers in different countries who were not so preoccupied with the details of the ethical discussions, but they really wanted to scale up testing, and they moved, in fact, faster than WHO. By the time WHO issued its guidance on provider-initiated testing and counseling, a number of countries had already moved. But still, there are questions that everybody was grappling with, which I have listed here. Can we ensure consent when we're routinizing testing? What are the benefits of testing, and can we ensure that people are linked to those benefits? Can we avoid adverse consequences? What about confidentiality and partner notification? And how do we think about the issues of access, expanding access and equity? So that's where the project came in, to think about what sort of evidence would inform these debates. And the project was characterized by a combination of epidemiological approaches to really document the frequency of outcomes and be able to conduct statistical analysis on the variables on the data that we collected, comparative approach, so multiple settings, and also look at the client's perspective to complement the manager's perspective that we have a lot of sitting at WHO or ivory towers. So the research questions were both public health questions to see how programs were doing, and social science questions because of my own training both in epidemiology and social science. I'm always interested in trying to really understand how people are thinking about what we're thinking about. Are we thinking about the same things? Are we interpreting the situations in the same way? And what are the implications of potential discrepancies there? Some of them could be good, and others should lead us to rethink how we're doing our work. So part of the project was designed to examine the services with the goal of improving them, and part of the project was trying to understand across cultures how people are thinking about these profound issues of consent or confidentiality or risk, gender, etc. The MATCH study, this is a brief description. It was conducted, MATCH stands for Multi-Country African Testing and Counseling for HIV. It was conducted in Burkina Faso, Kenya, Malawi, and Uganda, countries with different levels of prevalence at the time of the study. I'm sure those have probably been updated since. It was carried out with funding from the National Institutes of Health over 5 years. And it was multidisciplinary, and we had collaborators in the countries as well as in academic institutions in the US and Europe. So the core of the project is a survey of clients at health facilities, about 1,000 respondents in each country, of whom 2/3 were expected to have tested and 1/3 not. We tried to overrepresent people who would be HIV positive by selecting facilities. So I don't want to spend a lot of time on the sampling and recruitment, but basically we sampled facilities from a universe of facilities providing testing, and also facilities that don't necessarily provide HIV testing, because we wanted to compare people who would have tested with those who wouldn't have. And we also wanted to compare people who had tested through different modalities of testing, principally VCT facilities at the initiative of the clients, PITC facilities, including both medical facilities and facilities where antenatal care is provided. So we selected facilities, and at those facilities, we selected respondents in a systematic and not random way. It's very hard to think about, unless you are prepared to deploy huge resources such as the DHS and seroprevalence surveys, it's very difficult to think of community-based research on this topic. You do have to make some trade-offs and go to facilities and recruit respondents. So that's one of the characteristics of the study. We also had additional components that I will not discuss today. Some respondents who talked about their experience testing at home and others testing in the course of campaigns, a provider survey, and detailed interviews and focus groups. The analysis proceeded both along the lines of statistical analysis for quantifiable data from checklist and close-ended question, and textual analysis from the responses by clients to open-ended questions. So regarding the analysis of responses regarding access and quality, I just want to clarify how we did the analysis, because I will not go into great details of the results, but the first question was, are testing and mode of testing associated with socioeconomic status? In other words, do people who differ in terms of their socioeconomic background, are they more or less likely to test at all? And are they more or less likely to test at particular types of testing facilities? So for this part of the analysis, we looked at testing status on the right-hand side, whether tested or not, and where they tested. VCT, integrated testing, i.e. at health facilities, and PMTCT. And our independent variables are age, education, and wealth, which we measured in rather standard ways. The second part of the analysis had to do with the extent to which the 3 Cs, i.e. indicators of the quality of the services and of the extent to which they are respectful of human rights, are these different depending on where you test. So this is an analysis only of testers, whereas the previous ones compared testers and non-testers. And here, the key variable is the testing mode, VCT, integrated PMTCT. We control for age, education, and wealth, and we try to see if we have differences in the extent to which the services are in compliance with the quality indicators that are needed, and the 3 Cs. And those are, to what extent was there a proper pre-test meeting and a post-test meeting? To what extent was there counseling? Confidentiality was respected? Were people satisfied with the services, and were they referred in case this was appropriate? This is the result of the first set of analysis, which have to do with differences by socioeconomic status. The bivariate analysis showed that higher education was associated with VCT for both women and men, and that among men, wealth was associated with VCT testing. I'll come back to the interpretation of these results. And then we did multinomial logistic analysis, controlling for covariates. And the main result, I'm sparing you the detail, but this is the main result. Standalone VCT, the adjusted prevalence ratio showed that secondary education made testing at VCT sites almost 3 times more likely, a little under 3 for men and a little over 3 for women. So, and also when we compared PMTCT testers, their socioeconomic characteristics were no different from those of non-testers. What this means is that secondary education triples the likelihood of VCT for both sexes, and therefore that health facility testing seems more accessible to the less educated. When we look at the second part of the analysis, the 3 Cs outcomes, this is a summary of the percentage of respondents who say yes to the question, have you had a pretest, did you consent, was your confidentiality respected, etc. And what you see is that the percentage of complete indices are generally pretty high, 3/4 or more, except for the post-test index, which did not always take place. And I can explain what went into these indices. It was based on close-ended questions where we ask people, for example, did the provider explain to you what your test mean? Did they talk to you about prevention? Did they recommend that you speak to your partner? So we created indices out of questions like that to produce these indicators here. And so the post-test is a weak part. The referral is certainly not as good as we like it to be, and this was calculated for those HIV positive. But basically, the reports of completed services, in other words, conformity with standards, are pretty high. In the unadjusted analysis, integrated testing, i.e. testing at health facilities, seemed to do better than the other modes of testing. We did find significant statistical differences which showed that VCT was doing better for some of these indices, but you will notice that the differences are pretty small. They're just barely over 1. So overall, we can say that no mode of testing was consistently more favorable, and therefore that scaling up testing can be done through multiple modes without detriments to human rights. In summary, PITC is associated with lower socioeconomic factors than VCT. There are few significant associations between mode of testing and the 3 Cs. There are some variations in different indicators and weaknesses, especially post-test. So this is where there's homework to do. But in general, the results show that PITC reduces barriers to testing, that PMTCT improves access for women. Remember, we found no difference in the socioeconomic characteristics of women who didn't test and women who tested through PMTCT. Therefore, we could scale up testing with the scaling up testing is not associated with worse services, but there's certainly a need to improve and monitor the quality of services. The study has the limitations that I mentioned before, but in general, it gave reassuring results about the expansion of testing, again, which were really of concern for many of the human rights activists. Still room for improvement, as we said, for post-test. It also raises the question, what about the men? Because we all know PMTCT is reaching the women. We do not have comparable ways of reaching the men. And so the question is there, and we need to think about outreach, and hence all the efforts that we heard about in the first part of this presentation. I'll move now to the second part of the presentation of the results, and this is about an analysis of consent, which I had a lot of fun doing, and I hope you're going to find it interesting. This analysis of the data came from noticing a discrepancy in the quantitative results that we had. We found that when we asked people, did you have a choice to test, 88% said yes. This is across all 4 countries. And when we asked them, did you have the opportunity to refuse a test, 93% said yes, they had that opportunity. And yet we had a question where we said, do you think you could have said no? And only 23% said, I could have said no, I could have refused. Now, for those of you who followed the debates about consent and the literature on this subject, there were a couple of seminal papers that were really raising concerns in this area, where women, for example, there was this article on South Africa which showed that women who had agreed to participate in a project and be tested, when they were asked later, could you have said no, I think it was 80%, I want to check what the number is. Yes, 88% in South Africa said no, I could not have said no. And this was interpreted by the authors of the paper as indicating that they had not consented, that they were coerced, and there were all these discussions about power differentials between providers and clients, which were the concerns in the course of debates, which said, how could a woman say no to a doctor who tells her we're going to test you? Women are in a bad position to accept. There were similar data in a study in Botswana. 68% also said no, they couldn't have refused. A study in Kenya, only 20% thought they could have refused. So there was good reason to really see, okay, are we really, we have these data that I presented to you showing high levels of consent. Is this actually incorrect? Are people accepting, but accepting under duress? What does this mean? And so the strategy was to go back to some of the open-ended questions we had asked and recode them, conduct textual analysis, and see whether this was going to confirm a degree of coercion or not. And so I think that's it. So we actually embarked in a very painstaking textual analysis. Now remember, I think many of the so-called qualitative studies that we read about, it's often if you focus group, 25 respondents, 50 respondents. Here we had more than 900 people on whom we had open-ended questions, and it took a great deal of effort to really recode the text. We didn't want to, so the questions that we were recoding were the kind of question where we said, do you think you could have said no? And then they gave their yes-no answer, and then we said why? And that was totally open-ended and recorded as closely as possible to verbatim. And then we recoded those kinds of answers. And we had other sorts of open-ended questions that we also brought together that had to do with why they tested. And then when we recoded this text, we didn't come with an a priori set of categories. We just read and say, has this person consented or not? Has this person been coerced, etc.? And then we came up with the categories that are in the box at the top of the slide. We had a category of active consent. So these were people who said, so when we told them, why do you think you could not have said no? Or in other parts of the interview, they talked about why they tested. They said, I wanted to test. I had made a prior decision. I had health concerns. I wanted to find out about my status. So people who spoke like this, we categorize as actively having consented. There were people who said things that indicated they had not made an active decision, but when faced with the opportunity to test, they were rather nonchalant. They didn't mind. They found themselves at the clinic. They accompanied a sister. They sort of went along with testing. So this we categorize as no objection. They had no reason to refuse. So it was more not refusing rather than actively accepting. There were people whose statements were ambivalent. They said contradictory things. You could say that on the one hand they might have been forced. They said once you decide you can't go back. Or they'll say things, I don't know what happened to me that day. I have no idea why I accepted. So these are not people who were forced, but they're not people who really accepted. So we categorized them as ambivalent. Then there were people who said, I didn't know I was going to test. I was forced to test. The health worker told me I wouldn't be able to get prenatal care unless I tested. So wherever there was mandatory, we categorized as no consent. And then there were some responses that remained unclear. We really couldn't categorize them, and we left them as unclear, indeterminate. So when we forgot what people had told us about whether or not they could have said no, we found percentages of active consent which were quite high at 60%, and those with no objection represented 24% of respondents. And the respondents who were clearly not having consented were only 7%. And in fact, the graph shows you how the cross-tabulation, if you will, of the category of consent above with could you have said no, and you see that most people who did not think they could have said no were actively consenting, that among those we categorized as no objection, there was half who could have or not could have said no, and therefore that could you have said no is not really an indicator of consent from that point of view. We also did some further analysis of the reasons why they thought they couldn't have said no. Most of them said things like, well, I mean, I had already decided. This is why I went to the clinic. How could I say no? So when you said, could you have said no, you're not really measuring if they were coerced. You're just getting and it's still an interesting question. It's not a bad question to put in your survey because it's really telling you a lot about people's reasons, but it is not a good measure of consent. About a quarter of people were saying, I couldn't have said no because I really needed to find out what was happening to me. I needed to ensure that my child is not infected. So these were health concerns, why people thought you could not refuse. If you're pregnant, you really need to know for your child. So these were the kinds of answers. About 1/5 of respondents referred to the influence of the provider. And when we looked at the sort of responses, we saw that providers can really exercise a range of pressure on clients, from being just friendly and convincing and taking time with them, to putting a little heavier pressure, to telling them it's mandatory even though they're not supposed to say that to them, to really talking down to them and really forcing them to test. So there's a range, but it's not really all coercion. Some respondents talk about the providers as having really helped them understand and decide. So the providers were convincing, but the client was convinced. When we looked at, so we took back a lot of these recodes and we did statistical analysis on them, and we really did not find significant associations with the covariates. So it's not like one group of respondents was more likely to not consent or to consent. The only statistically significant association we found is that women and those who were HIV positive were more likely to be in the active consent category. So again, this was pretty reassuring. The summary of this analysis is that consent, even though we would like to think of it legally as binary, as a yes-no concept, it's really not necessarily binary. And we could think for ourselves how we go about some of health decisions, whether it's about dental care or mammograms. I mean, nobody's very happy to do these sorts of things. People might be ambivalent, and then they'll just do one thing or the other. And consent is not necessarily so clearly defined. The percentage who did not consent was pretty low. And if we had used the closed-ended question about could you have said no to give us an estimate of no consent, we would have been grossly overestimated the lack of consent. Providers do exercise some influence on respondents, and this is both good and bad. The fact that 1/4 of our respondents were in the no objection category is interesting, because what this means is that many people are on the fence, they're undecided. And therefore, if we have convenient services and nice providers and circumstances that really help people, they'll decide to test rather than not test. And that's a significant, I mean, it's a considerable percentage, 1/4 of people who could be convinced to test if we had services that were friendly. It reminds me of some of the discussions, you know, in the 70s about family planning. It was similar sort of debates about should the services, you know, are people agreeing or not. But if you put the services there and they're friendly and you give choice, people end up using them. Could not have said no is not an expression of being forced, but it could be very much an expression of agency. I couldn't say no because I had decided. I had made up my mind. So we need to think about it in this way. I think this has implications both for measuring consent and thinking about consent, and also for thinking about the way in which ethical notions that are defined by experts, lawyers, ethicists, and specialists in these kinds of circles where we live may or may not fit with the experience of these same notions in the field. I come now to the last part of my presentation. How am I doing on time?
You're fine.
Okay. And this is another part of the analysis which I thought would be of interest. That's the one part that's not published, that's not been submitted yet, hopefully in the next few days. And this is about reports by partners about testing experience. Of course, with the issue of discordance and the efforts for couple testing, we thought it would be very nice to look at our data and see what we have about couples. And in this analysis, we actually wanted a very broad definition of couples. We did not want simply to be limited to those who were in the closed-ended questions, who defined themselves as either married or cohabiting. So what we did is we read through the entire interview text, and anybody who referred to having a partner, for example, a guy I slept with or a woman I was having a relation with, or we categorize as being, quote, partner respondent. So this is a broader category than simply being in a formal union. And then we looked at how these people talked about their experience of testing. We looked at what they said before the test, at the time of test results, and after the test. And our analysis and recode of all these texts, we have approximately 1,500 respondents on whom we can then calculate some of these outcome variables that we're interested in. And so the first part is on this slide, where we're comparing women and men, and the percentages who say that they talked with their partner and this was a reason for them to test. So we find about a little over 1/3 of women and close to 1/2 of men. If there is time, I'd like to come back to this difference, which happened to be statistically significant. We also had people who said that the reason they tested is that their partner was exposed. They thought their partner was sick, or their partner had some reason why they thought they should test. And partner exposure was higher for women than men, and significantly higher. And we also looked at whether people expected their test results, and found that a little over half of women expected their test result and 61% of the men, which is quite high when you think that 40% of people are surprised about their, 40% of men and 45% of women are surprised about their test results. It's kind of something to think about. In looking at the texts that we have from how people describe their experience, I'm just highlighting a few of the results that I found interesting. One is that in a lot of the literature, women are described as not being able to test because of husband's opposition, and in fact what we see in these texts is that many women actually manage to test despite their husband's opposition. Sometimes they can convince him to test. Sometimes they just leave him and they say, he was just being nasty and I just decided to go test, or my children helped me and then I went to a testing site. So women are managing to test despite opposition. And that's an important thing to keep in mind, again, thinking about how to make it easier for people to test. One of the things we discussed in this paper about the ethics of testing, comparing what was happening in the 4 countries, was the difference between making it, how did we put it? Making it difficult to say no. So in other words, this is a degree of coercion, if you make it difficult to say no. What you want to do is make it easy to say yes. And so that's what we see in these texts. It is possible to make it easy to say yes, and people, in describing their experience, they show us how they do this, how it's easier for them to say yes in certain circumstances. We also have a theme that really came up, is that testing is not simply about testing. Testing is testing your relationship, your trust with your partner, and that really comes through in what we have in the materials from people across the 4 countries. And also that people exercise agency even when the circumstances are very constraining. Another interesting thing that we found is, as I mentioned before, more women were surprised by their test results than men. And that's an interesting gender difference because of all the discourse about being faithful. So women who have been faithful find that it's very surprising, why are they HIV positive? And we found something like that in a previous analysis, which was on Burkina Faso, which appeared in Social Science and Medicine. Same theme. This faithfulness concept is not very helpful for women because they might have been faithful but not their partner. And there's then expressions of betrayal. I think this is probably my last slide, where we're looking at, after the test, what are some of the outcomes that are interesting to think about. So disclosure to partner was less than half, and there was no significant difference between women and men in the percentage of disclosure. Abandonment by partner was approximately 18% of women and 11% of men. Now this is HIV positive respondents. made to feel bad by partner. The difference is significant, but it's really small. And then we also asked a question. We said, when you disclose your status, who was the person who was most disappointing in their reaction to you? And we asked them to describe. And then we asked them also, who was the person who was most supportive to you when you disclosed your status? And then we have text describing. And so when we analyzed this, we found that those who said their partner was that person who was most supportive, there were more men than women who were referring to their partner as being most supportive. I think some of these gender differences are worth pondering because some of them do go along with our expectations based on the literature, that women are at greater risk of having adverse consequences of testing than men. We did find this in the text. We had more stories of women who were evicted, who were told not to live in the same compound anymore, who were kicked out of their places of living. Whereas for men, there was more of a separation rather than eviction and abandonment. The one interesting thing that we were not expecting is, again, as we looked at the text as stories, we saw that there was a time dimension to them, that an initial reaction which was negative could have turned into a reaction of support. And this was very much gendered, because when we asked, you know, how is your partner acting towards you now, and then we listened to what people said, approximately half of the women said that their partner's reaction had changed, but nearly 3/4 of the men said that their partner's reaction had changed. So we're finding some gender differences that go along with our expectations, at the same time as we are finding some unexpected results where women are actually exercising agency. So in sum, this analysis, which combined the statistical and the textual, is really underscoring the importance of partners. Partners are present in discussions of HIV testing, in the reasons behind HIV testing, in the reasons for disclosure, which I actually skipped here. We asked them why they disclose, and we can go back to this if there is interest in it. What we found is that joint testing is very low. The results of this analysis do not make us very optimistic about couples testing in terms of going together, because there was more going independently than going together. The results also underscore the very emotional meaning of testing and disclosure, and therefore thinking about the test as more than simply the technical aspects of them. I've already mentioned the gendered experience of testing, the agency despite constraints, and then we're going to do an analysis of these data before we sort of put them to sleep, comparing the formal couples with the partnered couples, because in looking at these differences, it seems that there are some systematic differences that could be worth writing up, but I don't have those results yet. I think I've come to the end of what I wanted to share with you today. We have other ongoing analysis that we're writing up now. One is about the providers. As I mentioned, we have a survey of providers, and we have some of the text and responses about the way in which they're dealing with some of these dilemmas. And actually, we have a paper under review now where the providers are saying, how can I deal with the situation where I know this person is not going to tell their partners, and what should I do? Should I be complicit in the transmission of HIV, or should I inform? They are having these, I mean, some of the providers says, this keeps me up at night, I'm having a problem. Oh, okay. We have an analysis of the campaigns in Burkina Faso, which is also based on both quantitative and qualitative results. And I would very much like, when this is finished, to really step back and look at all the social science literature on HIV, because I think it's really, there's insights from it, but there's not enough communication between the sort of social science insights and the policy. And so maybe there's room to do something on that. So thank you all for your attention.
Thank you very much, Carla, for sharing the last 5 years of your life. Can we have some time for some questions? Questions from the field and questions from the floor. Do you want to come up to the? If you want to come up to the microphone, if you're here.
I can try and shout. Thank you very much, Carla, and thank you, all of you, for the facets of those complex issues that you have so well documented and presented. I have one comment, perhaps, and a couple of very quick questions, if I may. One is that you showed us that the 3 C's were not hampering the coverage and the use of HIV testing. And that should not be misconstrued or misinterpreted in the sense that because the vast majority of women agree anyway, why do we bother? Which has been voiced by some practitioners. And so what you have showed here is that it's perfectly manageable. You didn't give us much information. You probably have it in your study results as to how much time and effort does it take over and above the routine work of people who are providing services. But even if you factor this in, maybe you can give us a gist as to whether it is a gigantic effort on the part of the care provider or it is manageable in general terms. One of the questions I have is that were you able, I suppose when you say we asked and we did, it's a large group of people and probably a different group in Kenya than it was in Burkina Faso, but I would assume that because you used, I take it, informed consent from those you interviewed, that they were aware of who the interviewers were, and therefore I wonder to what extent the response has been somewhat adapted to the persons they were responding to, whether there was a kind of author effect there, or just the fact that you were reassuring, or the person interviewed was reassuring the person interviewing that in fact, yes, there was an option for her to say no, but she didn't use it and she fully consented and so on. So to what extent you did some internal variance between the groups or any other sub-studies, nested studies maybe, that would have confirmed your results. And the last quick question is that, I mean, the whole thing is really so interesting, so rich. I wonder if you could, in your free time, also look at people who turn out to be seronegative, whether the dual testing and the sharing of negative results was a positive factor in relationships. That would balance out perhaps the fear of violence of discordant couples or women finding themselves negative and so forth, just to show the flip side of the picture. So, thanks.
Can I answer these, or do you want to take my question? Yes, thank you for these follow-up questions, which are useful to think about some of the implications of these results. On the additional time and effort to really implement the 3 C's, we do have, as I mentioned, a provider analysis in which we ask people to say how long does it take for counseling. I unfortunately don't have this information in my head. But what we do have to remember is that very often these HIV services are resourced somewhat differently from normal healthcare services. And I think that that's probably why we're seeing fairly high levels of satisfaction of respondents there, because the providers are trained to speak differently, to take a little more time. So it's probably not an easy question to answer. You'd have to really look at time use, you'd have to do observations to really answer that question. I suppose that it is extra resources to do that, and we all know, and people have complained that HIV services are getting more resources than other health services. So it's probably not a straightforward answer. About the possibility of social desirability bias, which is, I think, what you're talking about, in the one paper that appeared in 2012 precisely about the 3 C's, we did a sensitivity analysis, and we compared the respondents who were interviewed at the same facility where they had tested with those who were interviewed, I mean, and it was all random. I mean, we didn't have anything to do with that. Some people said, I tested there or I tested here. And we saw no difference between the, you know, we did not see more favorable results for those who were talking about the facility where they were interviewed and tested. So we don't think that social desirability bias is operating that much here. We also try to kind of give people some reassurance that this had nothing to do with their care and to give them some freedom to answer. But still, they are being interviewed at health facilities, and we can't totally discount that possibility. We just don't think it's playing a very big role. Disclosure of negative status. I suppose we could take a close look at that. I think we have that, but it's not in my head. I'd be happy to just check that. And usually our expectation is that negative test results don't really make much difference because people are happy and they just resume their life as before. They had a close kind of encounter with the possibility of severe illness, and then they're relieved that they're not, and it might make no difference, or maybe it does. I don't know. I don't know.
We'll encourage you to look at that. David?
Thank you very much, Martina, Rachel, and the rest of the panel members for the great session. I think the previous speaker also, in a way, I think also talked about the issue of informed consent. I think also aligning to your question, whether informed consent can be obtained in a routine setting. I think my sense is most likely not, because usually for routine settings, it's kind of taken as an explanation. I am the doctor, these are the things that I'm going to do for you, and an HIV test is part of it. So here we go. So I think in a routine setting, my sense is we will not get informed consent. If we will not get informed consent, then we have to make sure that when something is routinized, it's acceptable in practice and generally agreed as a good thing. The questions I had, they are more like clarifications. First, I think on your presentation, did you also look at the uptake of HIV testing and counseling by geographical locations in terms, for example, rural areas? You looked at wealth and education, which confirm, I think, what we generally know, that access to HIV services seems to go along the wealth line. But now we have evidence indicating that rural areas are not accessing the services. So did you look at that? And then I was looking at your division. I still don't get the rationale why you had 2/3 of your respondents who were tested and a third who were non-tested. So I was trying to look at that, and I still don't understand it. So out of curiosity, what was the reason for that? Then on the first presentation the first presentation on the rapid tests and the self-testing, I was just also checking if there are plans to sell the rapid test using the social marketing programs. Because my sense is that if we sell, I think the people who need the services most, who are usually the poor and those in the rural areas, they will not get it. So just checking if there were opportunities for social marketing. Then my last one is on the triage. Like all the presentations, I really liked it, and I would like you to talk a little bit more on the triaging aspects. I think you spoke more on the care part. But like she said, for the HIV negative, it looks like, yeah, you are HIV negative, and nothing gets done for you. So I didn't see anything in terms of triage for the HIV negative people. Then I think on the issue of the HIV positives, the false positives, I think even with the issues she mentioned, our colleague from WHO on quality, she mentioned, I am not so sure for false positives, I'm not so sure we should worry about it, because people are going to get confirmatory tests. Unless the practice is so bad, generally, then we should worry about it. But I think for me, my worry would still be on the false negative. I don't know if you would talk about that. Thank you very much.
A lot of questions for all the presenters, so maybe really quite quick on some of them. Carla, do you want to start?
Yeah, I tried to be very quick.
Yeah.
I think that you might have misinterpreted some of the results, because I think some of the reports that we have about consent in these data come from places where testing is routinized, and we are still finding high percentages of consent. So I think that's precisely what these results show, is that when you scale up testing through health facilities and routinize them to a certain degree, you are not compromising consent. The second point is your point about access being associated with wealth. I think that's also a slight misunderstanding of the results, because what we did find, in fact, is that, for example, in the case of PMTCT, there was no difference in socioeconomic status between testers and non-testers, and therefore we cannot say that there are problems of access that are socioeconomic. And also, we also found no statistically significant associations in terms of socioeconomic status between PITC testers and in other words, we didn't find an association of socioeconomic status with testing for PITC. We found it for VCT. So there's a little bit of a nuance here to keep in mind. And lastly, about the proportions in the sample, we did sample calculations for some of the variables that we needed to have to be able to detect through statistical analysis, and because there was more that we wanted to look at in terms of testing, so we had more testers than non-testers. That's a quick answer.
Cheryl, do you want to?
Yes, just to address your point about social marketing, I completely agree. I would say there was a very fruitful discussion at the meeting in April that discussed some social marketing ideas. So that's on the WHO website, so I'd refer you to that. And we're also aware of a few proposals out there to do this type of work and to look at how social marketing could play a role. I think that there's just been more emphasis on figuring out the packaging and the product of how this is going to work. So that's really where some of the research has been at this stage. And so for implementation of social marketing, I think that's things to come. We're not quite there just yet.
Just to add to that, your question about cost, certainly in Malawi they have done some market research assessing the ability to pay, and as you can understand, it will be very, very low. I think really across all the presentations that we want to get increased access to testers, and maybe there are a whole load of different modalities. The VCT model, as we know, is maybe something that is accessible to more educated and high-income people. There may be different models of having self-testing available, and social marketing may be something that can attract people with higher income and take that burden off other forms of testing, which can be supporting people with lower income and people from rural areas. Do you want to just quickly say about what we do for negatives with the test and triage? I mean, I think you're absolutely right. This is something that we absolutely want to emphasize, that we don't want to leave negatives out, and that will be very context specific. We want to look at particularly negative men, supporting them for male circumcision projects and programs in the in the MC priority countries. Definitely negatives. We realize we haven't haven't offered enough linkages and services for, and we want to emphasise that. I think the quality...
Yeah, I mean, I'd have to disagree with you about not being worried about false positives, particularly in the era of option B+. We have women that potentially only have 2 tests if they're in a prevalence of above 5%, which is what we call a high prevalence setting. They only require 2 HIV tests. It's just unfortunate. The most sensitive, the best test in seroconversion, the best sensitivity is very poorly specific. It's around 97, 98%. So if the second test is not chosen well, so when we say false positive results, we mean false positive status. It's the actual status given to them in the end. And our worry there is that those women don't actually receive a CD4 upon treatment initiation. And we wonder, at what point down the track do they realise that these women aren't actually infected with HIV? Because there's really no other points to know. And so we obviously are concerned about sensitivity of tests, that is a given. But we're worried about over-diagnosing, over-classifying, and that leads to a wastage of treatment that's not needed and of monitoring. So it's a balance. It's very difficult, but it's a balance.
And just to add to that, I think this is what is really keeping us awake at night at the moment, is this idea that there may be a lot of people who are misdiagnosed, particularly the false positives, and it's not necessarily because of the poor quality of tests. The tests may be very good, but I think as Anita emphasised, it's because they're not being performed correctly according to standing operating procedures. People are not necessarily trained enough in how to do them, or not observing. So the quality of the performing of tests is something that we are really, really concerned that we need to improve and be vigilant about.
Just thank you to all the panelists, and I also wanted to congratulate Carla for this presentation. I remember when you started some of this work, so it's really nice to see this come to this stage. I had a few questions. I'm not sure all of them can be answered now, but these are more thoughts. The first one was in relation to some of the discussions on self-testing and whether there's been any conversation or discussion on what happens to the counseling piece. Because that would be an important consideration as we think about both the community level testing as well as self-testing. So that is the first piece. The second question I had was on the disclosure data here, since it's up, and whether there's been any analysis on significant proportion of people who didn't disclose and why. So whether if there's any data, just if you'd be willing to talk a little bit about it. The third question I had was on your interpretation of agency, and it's just a question I had about the interpretation of it, partly because it's already a fairly motivated group of people who you drew samples from health facilities. So I'm assuming that it's already a little bit of a selection there, but also because and it depends on how your analysis fell out. But if it is women who were already seeking care for pregnancy, then I imagine that the agency also comes a lot from being motivated to offer something for their children. So just maybe thinking about the interpretation of agency from that perspective. And then the other one was on, I was struck by the data which said that your index scoring on the post-test component was low, and I'm just curious what that means. And then the last question was on the joint testing and the fact that you said joint testing is fairly low, and given that we're recommending couples testing and counseling, was there any exploration or questions around whether this was preferred, whether this was because services were not available, whether the people you interviewed actually had any preference for joint or not? So it just would be helpful to unpack some of that.
I'll quickly answer your self-testing one. Self-testing, by definition, doesn't involve a pre-test counselling. Now, many of the models that have been used have a way that people can access post-test counselling, and we are at a stage where we are still exploring what this really means. And and as these projects get more, we get more data and more analysis, we'll know much more. I think one big role for self-testing will be in repeat testers. So they will have already had the pre-testing. And there are other models where the pre-test counselling can happen. It's just the testing can then happen at a different, in the privacy of their own home. So I mean, I think we're still in a bit of a learning curve here.
I was trying to find the exact percentage of PMTCT testers, and I don't easily find it here. But certainly, it's not the case that all women tested through PMTCT. So I think that's part of the answer to your question. Disclosure and non-disclosure, we did focus a little more on the responses to why people disclosed. We can go back and look at reasons why people did not disclose, because we did have that question. It's just not part of this analysis. I think we asked people who did not disclose if they intend to disclose. And in any case, disclosure was fairly high. The percentages you saw here are partner disclosure, not any disclosure. So disclosure in general was fairly high. I don't want to say a figure without checking it, but it was pretty high, 3/4 or more disclosed to anyone. And about joint testing, yeah, I've thought a little bit about this because I know how important it is to to have these results have some relevance to this very important issue. Having read through these materials and thought about what is it that people were describing in terms of their interactions with partners, I don't think joint testing is the way to go. I think partner testing is probably the way to go, but not joint. I think people should be supported so that, the two partners of a couple test together, but this area is so fraught with questions of trust and relationship and all that. I'm not sure that the health services have enough resources to deal with all the complexities of actual joint testing. But I do think we should support partner testing and couples testing. And whether it happens at the same time with two people finding out at the same time what their relationship has been, it seems to me very, very complicated. But I think I have more expertise to my left, and I should let Rachel talk about this.
Well, I don't know if I've got more expertise, but certainly I would agree with what you say. In reality, I think partner testing is actually what will happen in many services. And I think it goes back to respecting the views of the person who wants to involve their partner. And I think people who want to involve their partner and want to disclose, that is absolutely the key. And I was interested, in your abandonment following the testing. This is something that we always worry about, but also it may be a positive thing sometimes, in that, and this was something I was very struck with in some previous work that I did, that positive women who are in an unhappy relationship, it may be something sometimes that is the right thing if they want to disclose. But if they don't want to disclose, that should also be very, very much supported. And I think we should really listen to the views of the women and the men in this.
Yeah, I very much agree with this. First, the actual abandonment is not that high. But it could be the right thing. If people who have been in a rather abusive relationship, etc., then, it's fine to not to discontinue it. And you see some women who just don't want to continue. Yeah.
Hi, just a quick question regarding the ages of people who were included in your study, and if there were any young people included in the study. And if they were, was there any age disaggregation with some of the results to see if there are any differences around those who are younger, around disclosure and consent and access?
This was about adults, so 19 and above.
And
So
nothing from like 24 to 18, because often...
in some of the analysis, we did see effects of age. I can send you some of the details. There wasn't a lot of consistency in how age was operating to influence most of the results. But we did find statistically significant associations with age.
I think Alice is raising the flag for adolescent research, and I think this is a really major gap that we have in all our studies. We always do the easy thing, which is look above 18s, and we miss out on that, and I think that's a plea to your fellow researchers.
First of all, thank you very much for organizing this seminar. I learned plenty of things I didn't know anything about. And my question is, that relates to waste. I guess that traditionally it has always been a topic with hazardous waste relating to laboratory testing. But how about with the self-administered tests? I think they are less dangerous, but if the more you reach out to the communities, the more waste you will generate, and I'm wondering to which extent you have been working or talking to suppliers to have a strategy to take it back.
Yeah, I mean, it's an interesting question, and it's one that we think about a lot, because rapid tests can be used for HIV self-testing, and they can be of any format. So it could be blood-based, it could be oral fluid-based, etc. Obviously, oral fluid is advantageous in that theoretically the device and the developing solution should not be infectious after it has been used. And so that is actually an added advantage of using an RDT that uses oral fluid over using an RDT that uses whole blood for self-testing. However, the whole blood RDTs are about 10 times cheaper. And so if we're talking about cost being a barrier for accessing self-testing and accessing testing, oral fluid tests are, at the moment, as they are priced at the moment, they have some advantages, but they have some disadvantages. But I think we also identified that even with facility-based testing and the current blood-based rapid tests that are used, that waste disposal is an issue, and we talk quite a lot with actually the manufacturers to make sure that their tests could be disposed of easily. So obviously a paper-based cardboard test versus something plastic versus a dipstick. So these are all considerations we do make.
Thanks, everyone, and thanks, Carla. That was really interesting. You mentioned a number of gender issues. You mentioned about the access by men, and are there any other insights that you could share on the side of men accessing testing and counseling?
Not specifically from this study, I have to say, but in this other study we did previously in Burkina Faso, we had more about the difficulties. Well, no, it's not true. We also see it in this study. The difficulties that men have in going to health services in cultures where it's sort of better to be a tough guy and not acknowledge that you need help. In Burkina Faso, where men have to provide for their families, they don't like to go to those NGOs that give food support and help with care. So it's clear that for men, we can't count only on health facilities. For women, they're used to taking their children for immunization, and in my other work outside of HIV, the clinic, the health facility is a context for women to socialize. It is a feminine space to a certain extent in a lot of cases, and men feel excluded. So I think that accessing men We have to think more about workplace. We have to think about other mobile outreach in order to encourage men to test in the settings that are manly.
Well, thank you so much for all the good questions, and thank you for our presenters today. It has been very insightful, and I hope it's a discussion that will continue off camera and offline. I wanted to just say that all the materials that are here today, slides and also supporting materials, will be made available to everybody. So we'll be sharing a web link. And I also believe for those of you that are still in the room, should you be interested in sort of being more actively involved, that there is a list at the back of the room where you can sign up and we can engage you more proactively. Thank you so much for your time.